TB member of Rajasthan for Central IAP. He was in 2021 and also this year 2024. He's a member of Advisory Board of Indian Pediatrics 2024. Active member of the project IAP Ki Baat Community के साथ. He's also National Coordinator of Grid Module 2024. Sir, we would need your help in this. We are going to host one of the grid modules in Delhi. And sir, the list would go on if I continue, but just to mention a few more things, sir has presented more than 200 scientific papers in various conferences, organized more than 500 free health checkup camps, published more than 10 booklets, 16 posters at national level. Sir has been the organizing chairperson of Raj Neocon 2017, convener of North Zone ICANCL 2010-2017, co-chairperson of Raj Neo Pedicon 2014, had also been the president of IAP Udaipur branch in 2025 and 2026. And sir has also been the organizing secretary of Raj Pedicon in 1989. Our other co-chairperson for this session is none other than Dr. Renu Borelkar. She's a senior consultant in pediatrics, executive member of Central IAP in 2023 and also 2024. She's a gold medalist in her MD PEATS, speaker in regional and state and national conferences, PG guide for DNB and CPS students, and trained in ECID, MSU, and clinical clues. Triple S, I'm not aware of this full form, pardon me for that. And she has special interest in intensive care adolescents, pediatric rheumatology. So over to our chairperson to introduce our speaker and the moderator for this session, sir. Sareen, sir. Renu, ma'am.
Do we have a CV?
I shared it. I'll share it with you, ma'am, right away also.
Yeah.
Shared, ma'am.
It is not visible on the screen.
No, I shared it on WhatsApp, ma'am.
Okay, 1 minute, sir.
और डॉक्टर सरीन के साथ भी शेयर किया कुछ डॉक्टर मुकेश?
किया हुआ है सर, सरीन को सब शेयर किया हुआ है सरीन सर को.
Yes, sir.
Sir, you can do it, no problem.
Okay, sir. Should I start with a lot of welcome to all my friends, especially the speaker of today, main speaker, Dr. Sushil Kabra Saab, and also the main speaker, Dr. Anil Sachdeva Saab, my younger brother, Dr. Alok Bhandari, Dr. Renu, Dr. Kaushal, and the backbone of today's function, Dr. Mukesh. And I will say respect to Dr. Anupam Sachdeva sir, who is the father of hemato-oncology chapter. So he is providing blessings to whole of the North. So my respect to him also. He is not there. And all dear friends. So today our first speaker is Dr. Sushil Kabra, MD DNB, and also the professor of pediatrics, AIMS, New Delhi. He is editor-in-chief of the Indian Journal of Pediatrics. Research interests cystic fibrosis, which is the subject of today. Asthma, very popular in all the undergraduates and postgraduates and all the faculty for asthma. He is the key person for the asthma module. Then tuberculosis, diagnosis, and then the acute respiratory infection. I remember when you were in Professor Saxena's oration. So in ARI, there were a lot of queries and he very quietly solved all the queries regarding ARI. He has 690 publications, 690 publications and book chapters, 200 book chapters, orations 15, guest lectures 900, citations 12,000, H index 52, I-10 index 300. So this is a huge list, huge figures. And the books published by him are the Essential Pediatric Pulmonology, 4th edition, Essentials of Tuberculosis in Children, 5th edition, AIMS PICU Protocol, 9th edition, and Case-Based Review, Pediatric Pulmonology, 1st edition. And I remember that in COVID time, the government of Rajasthan had to formulate the COVID guidelines, and he was the key person in that. And very well organized key guidelines were provided to all the institutes in Rajasthan. And he has special affection for Rajasthan. And sir, I welcome you, and you please enrich all of us with your experience and your talk on the very, very important topic in pediatrics, that is the cystic fibrosis. Welcome you, sir.
और डॉक्टर अनिल सचदेव का इंट्रोडक्शन भी डॉक्टर रेनू दे रही है।
हाँ देती है, अभी दे देना है सर।
हाँ जी, हाँ जी।
Yeah, good evening one and all, the stalwarts of all IIP India, Delhi, as well as from the country. I would like to introduce our Dr. Anil Sachdeva sir, who is the Director, Pediatric Emergency Critical Care and Pulmonology, Co-Chairman, Department of Pediatrics, Institute of Child Health, and Sir Gangaram Hospital, New Delhi. Sir is the past president in Pediatric Respiratory Society, Delhi 22-23, past chairman elect IIP Intensive Care Chapter 2014 and 15, editor of Office Journal of IIP Intensive Care Chapter, the intensivist for last 4 years, and 2009 to 2012, co-author of Manual of Pediatric Intensive Care. He has contributed to chapters like IIP Textbook of Pediatrics, Pediatric Approach to Pediatric Intensive Care and Advances in Pediatrics, contributed to national and international journals, participated and presented lectures and conducted workshops. He has organized the Advanced Pediatric Intensive Care course for the last 18 years at Gangaram Hospital and has trained hundreds of young pediatricians in the intensive care, which one of was I at 20 years back. Executive member of Indian Society of Critical Care 2013-14 and 2015-16, executive member of Association of Pediatric Critical Care, running DNB and IIP fellowship since inception of the program, an examiner for IIP fellowship, and also DRNBSS since the beginning of the program. He has guided 12 DNB pediatric trainees, as well as having more than 70 publications in various national and international journals. Welcome to you, sir, on this dais. And good evening, all.
Good evening, everyone. And now it is my pleasant duty to ask the stalwart of cystic fibrosis, and rather Dr. Kabra is stalwart of many subjects. So he is the best person because he has worked on the basics and he has worked on the advances on the cystic fibrosis. So Dr. Kabra, please start your talk on cystic fibrosis.
Thank you, sir. Good evening to all of you and respected chairpersons and friends. In the next 40-45 minutes, I'll take you through the cystic fibrosis. And it is mainly meant for our students, DNB students. So I'll play less of a data, less of a science, more of the summary of all the details. And I believe that at the end of today's talk, the student will be able to understand genetics in brief, epidemiology, and more of a Indian epidemiology of CF in India, clinical features, how to make a diagnosis, a brief outline of treatment and prognosis. So let us see that cystic fibrosis is a autosomal recessively inherited commonest life-limiting illness in Caucasian population. And it is a monogenic disorder, and gene is located on chromosome 7. And as we'll be seeing that how the clinical features are produced when there is a abnormal gene of a cystic fibrosis or CFTR gene. The mutation spectrum in European population is that the commonest mutation is delta F508, which constitute around 75% of the patients in Caucasian population. Only a small proportion is constituted by other mutations. And it is important to understand that as you will be seeing, that mutations in Indian children with cystic fibrosis is different. So you can see here that various studies reported in last 2.5 decades that the common mutation, which constitute around 75% of the CF in Caucasian population, in India, it is variable only 20 to 30%. And you can see here, this is a complete genomic sequencing of CFTR from children attending AIMS. And you can see that it is so heterogeneous, so many mutations are there. And now we are collating the data of various part of our country, and it is a geographic specific mutation that we should be aware that those students who are reading, say, from the textbook of pediatrics written by a Western people, then you will understand that if we do a screening for say 12 or 14 mutations, it will cover almost 92% of the patients in UK. But it is not so in India, as it is evident that so many mutations are there. Though still commonest is Delta F508, but it is only in 20 to 30% of the patients. Now, after this brief genetics, we talk about that what is the magnitude of problem. So as you can see here, it happens all over. And in Caucasian, it may be 1 in 2,000 to 1 in 3,000, and it is variable. And the Cystic Fibrosis Foundation of US, it's report that there are 30,000 children and adults in the United States are living with CF. Another 70,000 may be living in other part of the country, other part of the world, and approximately 1,000 new cases are born every year. And this is estimate given by the CF Foundation. Now we come to India. That the first case was reported in 1968 from PGI Chandigarh by Dr. Bhaku and his group. And thereafter, there are so many reports of CF from various parts of the country. We collated it almost a decade ago. And it suggests that the CF occurs in Indian population, possibly throughout the geographic or ethnic groups. It is not restricted to a particular area. And this again, data from generated almost 2 decades ago, published 2 decades ago, that if we see the children, 120 children at that time, which we analyzed, that place of residence, they are all over. And it is because AIMS being a referral hospital, we get a referral from all over. But even if we see their place of origin, it is all over. Some patients you see that they are from the Pakistan, and some from Bangladesh, and some are from the Bhutan. So it is all over, suggesting that CF does occur in Indian children. It is not restricted to a particular ethnic area or ethnic group or a geographic area. So, but still, the precise incidence of CF is not known. So we need, if we want to have a clear picture that what is the magnitude of problem, we have to estimate it. So if we say 1.3 to 1.4 billion people in India, and birth rate approximately 20 per thousand per year, total birth may be 260 million, and number of children with a CF per annum, this is based on, if it is 1 in 2,500, then we may be having 10,400 newborn born with CF every year because of huge size of our country. If it is 1 in 10,000, then 12,600 may be per year. And if it is 1 in 40,000, it may be 650. This is, I have taken from the literature reported till now from the India. So if you see the probability of a pediatrician coming across CF patient in his clinical practice, if we consider that there are 600 districts, there are 50 pediatricians per district, survival of CF patients even without treatment is 5 years, and each child may have a 6 episode of respiratory problem. Then if it is 1 in 2,500, a pediatrician is likely to see 10 children with lower respiratory tract infection or pneumonia. And if it is 1 in 10,000, 2 to 3, and even if it is 1 in 40,000, a pediatrician is expected to see 1 LRTI due to respiratory infection, and most of them may remain underdiagnosed. This is very interesting study published recently in 2020, carried out by Dr. Verma and his group in Sir Gangaram Hospital. What they did, they took 200 participants, 200 people who were not having any high risk group, and they did their NGS, and they found that almost 26% of them were found to be carrier of one or more of a disorders, and 9 individuals were observed to be carrier for cystic fibrosis. So out of 200 participants, 9 were carrying one or other mutation of cystic fibrosis, and this is by complete NGS. So if we say the frequency of gene comes to 1 in 22, which is rather more, but at least same as that of a Caucasian population. So higher frequency of cystic fibrosis disease was unexpected here, and contrary to the generally held view about the prevalence in Asian Indians. So if the same data are replicated, same results are replicated, then we can say that it is not extremely rare in Indian patients, but it is more or less similar to that of a Caucasian population, provided that the results are replicated. So after this brief epidemiology, I'll discuss about the pathogenesis so that it gives an understanding that how these clinical features are produced. So there is an abnormal gene, CFTR DNA, and absence or altered CFTR protein, which is not formed. There is a defect in iron transport across the chloride channel, and this leads to altered secretion. And secretions are very thick, viscid, which will cause blockade of the duct, impaired mucosal defense, and infection and inflammation. And that's how there is a cystic fibrosis disease. So now what happens if it is a thick viscid secretion in the respiratory tract, as you can see over here? So there is a thick viscid secretion causing impaired clearance. There is a plugging leading to a increased bacterial colonization, mucosal inflammation, and mucosal hypertrophy, and that leads to a recurrent LRTI, ultimately resulting in a bronchiectasis, as you can see over here in this X-ray. Hyperinflation, peribronchial thickening, suggestive of bronchiectasis. If same thing happen in pancreas, thick viscid secretion in the pancreatic duct, it will cause blockade. Then what happens in the in utero itself? When there is a blockade, there will be a back leakage, increased pressure in the pancreas, leaking it in the blood. And when you see at birth, there may be increased immunoreactive trypsinogen in blood, which is the basis for screening in the neonatal period. So it will lead to a pancreatic insufficiency, and it may lead to a meconium ileus, meconium peritonitis, steatorrhea, and failure to thrive. These are the problems arising out of the pancreatic involvement. This X-ray, you can see here, there is a calcification, there is an air fluid level, and a newborn with a peritonitis, meconium peritonitis. So increased chloride content in sweat, that leads to a salty taste on kissing, increased salt wasting, leading to dehydration in hot weather and salt craving. So this is one of the unusual manifestation of CF in Indian children because of excessive sweating and loss of salt and water. After this brief discussion on pathogenesis, now we understand that the main problem is because of the thick viscid secretion in the lungs and in pancreas, and there is a excessive salt wasting in sweat. These are the 3 major pathogenic processes. So what are the clinical features? So in neonatal period, it may be meconium ileus, which may be simple, which is which presents as a delayed passage of meconium or not passing meconium at birth, abdominal distension, and microcolon. Complex is when there is a meconium peritonitis because of thick viscid secretion, there is a blockade and the intestine ruptures, and there is a antenatal volvulus. Antenatal suspicion when a good sonologist see there is a altered bowel echogenicity, and after birth there may be prolonged cholestasis and wet cough and poor weight gain. 20% of children with CF develop meconium ileus, 15 to 20%. And 80% of those who are having a meconium ileus, CF is the etiology. So that is very important. Those newborn neonatologists, those residents taking care of children in the nursery and having these delayed meconium passage, meconium plug syndrome, and meconium peritonitis, think of CF and investigate them. So the clinical features, as you can see, it starts in utero in neonatal period, and in first 2 years, obstructive jaundice, hypoproteinemia and anemia, bleeding diathesis, heat prostration, and failure to thrive. This may be in 10 to 15% of the patients. Subsequently, almost 85% of children with CF may have a steatoria or exocrine pancreatic insufficiency. Rectal prolapse in 20% of the patients, and then recurrent or persistent bronchitis, bronchiolitis, and staph pneumonia. From 2 to 12 years of age, malabsorption, as we had seen, 85% of the patients, recurrent or persistent pneumonia, nasal polyposis, and intussusception. These are the other clinical manifestations between 2 to 12 years of age. And if a child is adolescent, then chronic pulmonary disease. On examination, there may be clubbing. And after 10 years of age, every year, 10% of the children may have an abnormal glucose tolerance test, diabetes mellitus, and chronic intestinal obstruction. With focal biliary cirrhosis, this is the liver disease, portal hypertension, gallstone, and almost 98% of the children suffering from CF will have an obstructive azoospermia. So they'll have a normal sexual function, but they'll not be able to produce children. But with the technology advance, they may have in vitro by taking a sperm directly from their genitals and then having a IVF. So these are the clinical features seen at AIMS. You can see these three: recurrent or persistent pneumonia, failure to thrive, and malabsorption in majority of the patients. And if this is an infant, you may not find any significant problem in X-ray if it is not told you that it is a X-ray of a CF child. But if you know, then there is a peribronchial thickening. You can see it because of repeated infection colonization, and there is a hyperinflation. But if child is a 10-year-old, you can see CT scan in which there is a central bronchiectasis. You can see there is a dilated bronchus. Along with that, some of these bronchi, dilated bronchi, are filled with mucus. So there is a mucus impaction. Atypical manifestations in Indian children may be because of weather conditions, delayed diagnosis, and inadequate treatment. So these children may have a severe hypokalemia, hyponatremia with alkalosis. This is called a pseudo-Bartter syndrome. So any child who is presenting, say specifically in first 2 to 3 years of age, may present with a severe dehydration without any diarrhea or vomiting, and then think of that why he is having this dehydration. And if there is a electrolyte abnormality, then we are very sure that it is a cystic fibrosis. And based on these our findings, I'll tell you about how to screen children by using these usual or routine investigations. Meconium ileus equivalent is another one, which is because of the pseudo-Bartter syndrome hypokalemia. And majority of the children at the time of diagnosis, they get colonized with pseudomonas because of delayed diagnosis, unscientific use of antimicrobials, and that's why they get more pseudomonas earlier. Vitamin A and D deficiency, fat-soluble vitamin deficiency because of exocrine pancreatic insufficiency, and delayed diagnosis. Some of these patients may present with A and D deficiency, which is not heard in a Western CF unit. CF score suggests that they are moderately sick. There is a seasonal variation in the growth. Generally, because of electrolyte problem, their growth is altered during the summer months, though they have a more clinical symptoms in the winter month. Significant lower bone mineral density, more allergic bronchopulmonary aspergillosis, and they may have different vitamin and mineral deficiency. And somehow it is more cystic fibrosis related diabetes in Indian children. And obviously any chronic illness will have some psychological problem, and those who are about 12 years of age, almost 67% may have a depression. And long-term complications, since they are now surviving beyond 15-20 years. One common problem is cystic fibrosis related diabetes. Another one is CF related liver disease, pulmonary arterial hypertension because of the chronic suppurative lung disease, hypertrophic pulmonary osteoarthropathy, and decreased bone mineral density. So after these clinical features, we say that how I can make a diagnosis. So sweat chloride is the gold standard, along with a clinical features, compatible clinical features, or a nasal transmembrane potential difference, which is restricted to a research laboratory, or identification of 2 mutations. And there are so many mutations. And as you had seen, screening for 3, 4, 5, or 10 will not give us an adequate answer. So sweat chloride, this is, we have indigenously developed sweat chloride system of our own for last 3.5 decades. And this is a very less expensive. The cost of this type of equipment will cost around 500 rupees and 25 rupees or less than that for a per test. While this commercially available may cost around 35 lakh rupees with a 5,000 per test. So we are doing this using this test, and almost 10 to 15 centers across India, they are using the same system which was developed at AIMS. Then we thought that what are the other screening tests which may be suitable for India? That is a aquagenic wrinkling. This is, we dip the child's hand in water at room temperature and measure time to develop a wrinkling. So the children with cystic fibrosis, they develop wrinkles very fast. As you can see here, almost all of us may develop it, but it may be after 15 to 20 minutes if we keep our hands in the water. But CF children, almost 81% will have a development of wrinkles by 3 minutes. But it may be, as I said, all of us may develop this problem, so it is not as specific. So in that case, we developed a clinical, based on the clinical features, along with that common these things, and we tried to develop a algorithm that you suspect CF presented based on our data, as you had seen the data, that a child presenting with recurrent persistent pneumonia with bulky fatty stool or failure to thrive, ask history of SIB death due to respiratory illness or sputum culture positive for Pseudomonas. These are the history alone, sibling death due to respiratory illness or sputum culture. If yes, then diagnosis of probable CF with a sensitivity and specificity of 85%. And you can start the treatment, though of course you can confirm it subsequently whenever sweat test or mutation is available. But if it is not there, but they are having a failure to thrive recurrent persistent pneumonia, then check for aquagenic wrinkling, look for hyponatremia, metabolic alkalosis, and stool for fat globules. If 2 of these are there, then you are reasonably sure of a cystic fibrosis. Again, the same sensitivity of 85%. So it is just history of a sibling died due to respiratory illness, sputum is positive for Pseudomonas, do aquagenic wrinkling, hyponatremia, metabolic alkalosis, and stool for fat globules, and you are reasonably sure that you are dealing with cystic fibrosis. So what should I go, which test I do? So if you are suspecting CF, clinical phenotype, basic lab test, and as this is based on the score, so you have made a probable diagnosis. Sweat test is available, document sweat test twice, and make a diagnosis of CF. Either you can use a macroduct or nanoduct, or indigenously made system can be used. And if sweat test is not available, which is a problem in our country, in that case, high suspicion of CF, like CF, SIB has CF, clinical phenotype of CF, then you can go for a sequencing of a limited CFTR mutation. But if the diagnosis is uncertain, whole exome sequencing in consultation with the geneticist. So this is the way how you can make a diagnosis of cystic fibrosis. So now in brief, we'll discuss outline of the treatment. So as of now, we do not have a cure. There is an improved median survival from 6 months in 1950 to 45 years in 2021 just by supportive care. And supportive care include mainstay of treatment is airway clearance. As we had seen, the basic pathogenesis is that there is a thick viscid secretion blocking the airways and promoting the growth of bacteria, and it may cause this problem of bronchiectasis and repeated pneumonia. Antimicrobial agents, as there is a colonization, superheated bacterial infection, we have to treat it aggressively with systemic as well as inhaled antibiotic, which we'll be discussing in subsequent slides. Nutritional management, pancreatic enzyme replacement, and fat-soluble vitamin replacement. Early identification and treatment of complications like cystic fibrosis-related diabetes, ABPA, chronic liver disease, etc., and psychological support. And I'll talk about a little bit about the disease modifier like cystic fibrosis, transmembrane regulator modulators, and gene therapy. So airway clearance or chest physiotherapy. This is the mainstay of treatment of cystic fibrosis. So most important thing is that we may ensure good hydration of the children, and we give them adequate electrolytes. And then we use various methods for doing physiotherapy. So postural drainage and chest clapping, active cycle of breathing, positive expiratory pressure, high pressure PEP, flutter therapy, autogenic drainage, and high frequency chest wall oscillation. So these are various ways, and there are multiple studies which suggest that none is superior to the previous one. And you can use or select one method for your patient after discussion and see that what is most appropriate. Because even if I say that you use a high frequency chest wall oscillation, which is very expensive, like 6 lakh rupees for a one waist, but it may be very effective in America, but it may not be so effective in our country. So that's why you have to see that if we can use these active cycle breathing or flutter therapy or some devices, that is more appropriate rather than suggesting a fancy and very expensive drugs, expensive devices. So then if the next question is, what is the role of mucolytic? When there is a thick viscid secretion in the airway, can we use a mucolytic agent to decrease the thickness or viscosity of these? So the secretions can be made, what all we can use to make them thinner. So one is recombinant human DNAs. The basis is that because the children with CF, they get colonized and then they are not having an immune deficiency. So there is a positive chemotaxis. So child's own WBCs, they come to the airway and they lyse, and then they release lot of DNA, and that is responsible for thickness of and viscid secretion. And what happens that DNAs, or it is recombinant human DNAs, it decrease or it cuts these DNA and it reduces the viscosity. And studies have so demonstrated that Dornase alpha or DNase improves the lung function, and it definitely slows down the decline in the lung function. And treatment effects are lost when treatment is ceased. Therefore, long-term maintenance therapy is required. So as it is, there is no carryover effect. As long as you give it, there will be improvement. This drug is not available in India, and in grey market, it may cost per day therapy of 2,500 rupees. Then another cheaper option is hypertonic saline, which is shown to reduce the pulmonary exacerbations, marginally improve the lung function, and currently used in majority in India. Like in our center, all the patients will get the prescription of hypertonic saline, which may be 3% or 7%. So we ask them to give salbutamol, followed by 3% saline by nebulization, and then aggressive chest physiotherapy, and then whatever other drugs, as we'll see, may be given. Another hypertonic drug is mannitol. An improvement in some measurement of the lung function in people with cystic fibrosis has been shown, and it is better than controls. And again, its preparation is not yet available in India. Mucolytic like N-acetylcysteine have not been proven to be effective in patients. We do use it in a selected patients like when there is a complete collapse of part of the lung, and when we do a bronchoscopy, we instill some for this N-acetylcysteine there, and then we do a physiotherapy. So now the major concern is how to manage exacerbations. These are the major cause of morbidity. Natural history of CF in a state of chronic progression with intermittent exacerbation. Pulmonary exacerbations are responsible for much of the morbidity and mortality, and it may be caused by viruses, bacteria, tubercular, non-tubercular mycobacteria, fungi, and responsible for pulmonary exacerbation. Initially, it will be usual infections like strep pneumoniae, Haemophilus influenzae, and once you treat them with appropriate antibiotic, then these are eradicated and Pseudomonas is selected. That's how majority of children will develop Pseudomonas ultimately, and once it is there, then decline in the pulmonary function is more. So this is data published 3-4 years ago from AIMS, that what are the agents which may cause exacerbation. So these include Pseudomonas, Burkhardt cepacia, Staphylococcus, Haemophilus influenza, and including virus like RSV, influenza, parainfluenza, corona, and HPMV, human metapneumovirus, fungal pathogens like Aspergillus candida, and mycobacterium species. So they get infection from all these mycobacterium bacterial agents, and more important is Pseudomonas because it will affect majority. And once there is a Pseudomonas, there is a rapid decline in the pulmonary function unless we take care of it. So important that we take care of a Pseudomonas. One is delay its colonization, and once it is there, then we treat it aggressively. Viral pathogens, they may not have an acute issue immediately, but once there is a viral infection, they promote colonization with Pseudomonas and Staphylococcus, and there is a rapid declining. So this is also important to understand that viral infection may not cause acute issue, but they are responsible for further decline in the pulmonary function, and we should be aware about it, and we should try to prevent it. The common microbial agents are Staphylococcus aureus, Haemophilus influenza, and as we had seen, so what should be our antimicrobial whenever there is an exacerbation? So first and foremost is that we decide that it is a mild and treatment can be given ambulatory, or if it is a severe, then he or she requires a hospitalization. So common antimicrobials take care of these organisms may be quinolones like ciprofloxacin, amoxicillin, clavulanic acid if Staphylococcus is there, oral first generation cephalosporin, and if it is a Pseudomonas, then ceftazidime, amikacin, and now it may be a combination of third generation cephalosporin with other drugs. And if there is a pulmonary exacerbation, so one of the principle is that we'll be treating the children for longer period, say 10 to 14 days, rather than 5 days or 3 days. Then aerosolized antibiotic. There are some aerosolized antibiotic which are being used in children with cystic fibrosis like colistin, tobramycin, amphotericin B, and now ciprofloxacin, aztreonam. Others are also, though they are not available in India, but they are being used. And indications would be if a child is colonized with Pseudomonas. And so how you define that once there is a Pseudomonas in the airways, and if we give the treatment and it is not getting cleared, in 6 months twice you are able to identify, you say that child is colonized, and we have to give them treatment. So options are that one is we give them inhaled antibiotic so that there is a good concentration above the MIC level, and then they can suppress the growth of Pseudomonas and other organisms. And you can give twice a day colistin, tobramycin, and if there is a colonization or aspergillus, then amphotericin B. So after pulmonary treatment, we come to the nutritional management, which is also equally important. So our aim is to increase the caloric intake. So encourage the child to eat energy-rich food and no restriction. So what happens is that the parents may feel that when they have stopped fatty meals, the gastrointestinal system may problems may improve, but it will compromise the caloric intake, and that's why the child will have a malnutrition. So that's why no restriction of food, but we try to increase the caloric intake and this is in addition to their routine caloric intake. So generally, the children will require almost 100 to 150% of the RDA for normal children. So how you can give these caloric caloric intake? So this is over and above the routine food, and this is something like you give them an additional glass of a milk. Children may be fussy, and specifically if they are chronically sick, then you may have to give them something to add to the milk, and that may be a skim milk powder or some flavored syrups and other things can be added, and then the child takes it. And similarly, you have to encourage more food. And in Indian children, you can encourage them to take some sweets made in coconut oil, because coconut oil has a medium chain triglycerides and which will not need antimicrobials, which will not need the enzymes. Okay. So if children are infected, obviously they may not be able to feed. And if they are having an infection, there is an increased caloric need. So we decide to give them a nasogastric feeding, and in good CF units, there is a possibility of gastrostomy feeding. And so indications for these would be if there is no weight gain for 6 months, even with adequate caloric intake, acute pulmonary exacerbations with poor oral intake, consistently poor appetite and inability to maintain caloric intake before major surgical procedure, and during periods of increased caloric requirement like puberty and pregnancy. So this we need to identify. Our aim should be to give them increased calories along with, as will come, enzyme replacement, and try to maintain their nutritional status. If we maintain their nutritional status, their pulmonary function are going to be good. Another thing is you have to give them fat soluble vitamins, and that would be supplementation with the A, D, E, K. And to remember it, that it would be almost 2 times the RDA of a ADE. And K will discuss in the next slides, that you give up till now, till few years ago, vitamin K oral preparation was not available. Now we have oral tablets available of 10 milligram. So if child is less than 10 kilo, 5 milligram once a week. And if it is more than 10 kilo, then 1 tablet a day, once a week can be given. And we should be aware that vitamin K deficiency may cause 2 things. One is it may lead to a bleeding diathesis, and it is equally important for the bone mineral density. Another important thing in our country is salt supplementation, and you will not find precise recommendation or doses of salt to be given, because it is not a problem in countries like UK, US, or European countries where there is not so much of extremes of the temperature, but they still supplement them during the summer months. So if a child is less than 10 kilo, 2.5 grams a day, 10 to 20 kilo, 5 grams a day, and more than 20 kilo, 7.5 grams a day, and potassium 3 milliequivalent per kilo per day. So these two electrolytes are to be supplemented, and this we have calculated based on the sweat chloride values of patients in India. And how we ask them that they have to give this additional, because it is a daily thing. So they can prepare small packets of 1 gram, and depending on this thing, if we ask a child who is less than 10 kilo, and he is supposed to take 2 packets of 1 gram, then the mother will give it with the food. If it is 5 gram, then by evening, 5 packets will be continued. This we generally start in Delhi from May till say August. Then major supplementation is pancreatic enzyme supplement, which has improved the survival of these patients. Enteric-coated spirules, because if we crush the tablet, then it will get inactivated in the gastric stomach itself. So it is an enteric-coated, which the coat will get cleared when it reaches to the duodenum, and then it is available for digestion of the food. And now spirules are available for last 2 decades. dose is 2 to 3,000 international unit lipase per kilo per day to begin with. So it would be, say, if it is a 3 kilo child, then he'll require 1 capsule of 10,000 lipase per day in divided doses of 4, 5, 6. But it is to be given with each food. This is very important, that before each food which has a fatty food, you have to administer it, and you decide by seeing the stool frequency, smell, consistency, weight gain, abdominal symptoms, and so on. So it is important that these capsules, or now we have a granules, are given with, we calculate that how much the child may need, and you give it with each food. So it is important that any food which contains fat, you need to give it. And depending on what is the fat content, you can give less or more. So for example, if it is a 3 kilo child and he takes 8 feeds a day, and we feel that we cannot give him more than 3 capsules a day, or 2 to 3 capsules. In that case, to begin with, you can start with 1/4 capsule per feed before giving a feed, and it is given with jam, jelly, or even sometimes some food material in the beginning itself, and subsequently the whole food is given. So enteric coated tablets are less efficient because it needs to be swallowed as such. So now we come to advances. So over last 1 decade or so, there are some molecules which improves the chloride channel function, because as you are aware that there is some problem in the protein formation for the CFTR, chloride channel. If it is not made at all, it is made, but it is not reaching to the surface of the cells or at the level where there is a chloride channel. So there are various groups of these mutation, and there are various groups of chemicals which may improve their function. So CFTR pharmacotherapy aims to increase the protein expression at the cell surface of its function with the drug therapy. One of the molecule is ivacaftor, is a standard of care in children with getting mutation.
कौन है?
And
मेरा बच्चा, मेरा छोना
getting
बंद कर दिया।
mutations, and these are not commonly seen in India. It is more commonly seen in the Middle East countries, and they are using it. And reports suggest that once you have started ivacaftor in the beginning itself, say during the neonatal period or during the infancy, then they are like a normal child, except that they have to take this medication regularly. Other CFTR modulators are those can be given to children who have at least one delta F508 mutation and 2 drug combination or 3 drug combination. And these are very expensive and as of now not available in India. So this is a chart of a patient who was started on this CFTR, and you can see that there is a improvement in the function as well as quality of life of these patients. And they are promising, but they are expensive. So you can see here that the treatment, you have to start with the counseling, clean environment, dietary advice, physiotherapy, and regular follow-up, no added cost. Basic radiology and lab test, vitamin and salt supplementation, bronchodilator and hypertonic saline, it may cost around 2,000 rupees a month. Pancreatic enzyme supplementation, microbiology culture, and SOS IV antibiotic may increase the cost to 6,000 on an average per month. Inhaled antibiotic and advanced radiology, it may increase the cost to 20,000 a month. And if you give a DNase, that is not available as of now, but if you give it, then it will be a cost around 95,000 rupees a month. And if you give these potentiators or modulators like 3 drug combination, then that itself will cost around 23 lakh rupees a month. So it would be around 25 lakh rupees a month of a total cost. So if you see, this is the area where if you give good physiotherapy, pancreatic enzyme supplementation, and some antimicrobial, area of maximum cost benefit. But if but as the medicines are advancing, then there is an area of a diminishing return. So even if you feel that the child belongs to a poor family, you should try to help them out by giving the appropriate treatment. And now CF is one of the rare disease, and Government of India may provide some support to the children irrespective of their parents' income, and we should try to take take advantage of that. So the treatment protocol is you give a pancreatic enzyme, fat soluble vitamin, and I have not discussed about the macrolide. Macrolides are given and have been found to have a immunomodulatory effect. So that's why all children at AIMS CF unit, they get azithromycin thrice a week or sometimes even daily. Vitamin A, D, E, K supplementation, potassium chloride supplementation, salt ad lib, calcium supplementation, and inhaled medication. As we have discussed, first give salbutamol, hypertonic saline, followed by chest physiotherapy, and then inhaled other medications. And other medications, as we have seen, inhaled tobramycin, colistin, or 2-drug or 3-drug combination of modulators. So what is the prognosis? There is a significant improvement in survival of CF over past 6 decades. Survival improved from median of 6 months to in 50s to 5 decades now. And in India, even there is a good survival, and many of our colleagues are treating them. So more than 25% of the patients at AIMS are more than 20 years of age. And these are various factors like if you have made a delayed diagnosis, if they are colonized at the time of diagnosis with Pseudomonas, if they are having more than 4 episodes in a year, and they are malnourished. In those situations, the prognosis is poor, and you can see survival is poor in those patients. So early diagnosis, improving nutritional status, decreasing colonization with Pseudomonas, and effective management of LRTI. So to summarize, CF occurs in Indian children, as I have shown you. Diagnosis is missed or delayed. Precise magnitude of problem is not known. Estimated frequency is 1 in 10,000 to 1 in 40,000. And if there is a replication of a study carried out under the supervision of Dr. Verma, then it is more or less similar to that of a Caucasian population. Clinical features are similar to Caucasian, more frequency of chronic salt depletion, pseudo-Bartter syndrome, fat-soluble vitamin deficiency, and diagnosis is delayed. At the time of diagnosis, advanced disease, malnutrition, colonization with Pseudomonas, bronchiectasis, and clubbing. When to suspect? Child presenting with recurrent pneumonia, meconium ileus, malabsorption, pancreatic origin large, foul-smelling bulky stools, significant steatorrhea, oil droplets in stool. If you find a child whose parents say that there is a oil droplet, it's very specific that it is a exocrine pancreatic insufficiency, and the reasons for exocrine pancreatic insufficiency commonest is here. Metabolic alkalosis, hyponatremia, hypokalemia, hypochloremia, Pseudomonas in sputum. Children treated with asthma and they develop a clubbing suggests that rule out either ABPA or it may be CF. Child always sick but has a good appetite, it may be CF. So you make a diagnosis with clinical features, supportive evidence, hypochloremia, hyponatremia, hypokalemia, sweat test, nasal transmembrane potential difference, and mutation analysis. And management, regular follow-up. This is the key. That if once you have made a diagnosis of CF, call them every 1 to 3 months, depending on what is the workload in your clinic. Enzyme and salts replacement, fat-soluble vitamin, airway clearance, mucolytic agents, and CFTR modulators, and prenatal diagnosis. So thank you very much. If I'll stop sharing, if you have any questions, I'll be more than happy to answer.
Thank you very much,
Right.
Dr.
Sir, go ahead, sir.
Yeah. So thank you so much. It was a very comprehensive talk on such a vast subject. The more you read about it, the more things you want to know about it. So I have been looking after these CF patients at Gangaram also. And of course, as you have rightly said, that the diagnosis is delayed, patients are referred late. And so for the general pediatrician or pediatricians who are at the periphery, the key is that they have to be aware of this disease, that this disease does occur in India. Number one, many of the people, they understand that the CF is a disease of Western country, which is not true at all. So, and then there should be high index of suspicion. So any child who's coming to their clinic for second or third visit with the pneumonia in a different locations, and the chest X-ray, and they require antibiotic therapy. So it is important that we should not label them with some diseases like he's suffering with asthma or something, and then send them home with the ventilator on the nebulizers or something. So high index of suspicion, awareness of pediatrician definitely will increase the pickup rate of CF in our population. Uh, as you have said that the diagnosis tools are not available everywhere, but as you have shown in one of the slides that the probability of CF is very high when there's a combination of clinical symptoms in the family history. So that is, I believe that is good enough to start treatment and in these patients, and later on, whenever convenient, the patients can be sent to the center where the sweat chloride or the other tests can be done. Uh, as far as the treatment part is concerned, you have covered up every part, and one cannot be, overemphasize the use of airway clearances, because what I have felt that the parents become little relaxed, once the cough, reduces in a child. So they have to be re-emphasized on every follow-up visit that the chest physiotherapy should continue even if the child is not coughing, and the child does not have any breathing problem. Even then it need to be continued, and that is the first and foremost important part of the treatment, besides other enzymes and nutrition and other, as you have mentioned. uh, Regular follow-up is also essential. What I felt that they are very keen in the first few months. They come for a regular follow-up and then they disappear. Either they understand the futility of their effort or they go to some other center. I don't know. But loss to follow-up is, the attrition rate is very high, at least in my knowledge. And regarding the modulators, I have no experience of using modulators in any of my patients. We just, whatever you've shown us in the sigmoid curve, that the basic 3 4 things, that is what we use very regularly. And we have a chronic lung disease clinic in our Gangaram hospital, and we have good number of patients in a follow. Uh, I can see in the chat questions, there are certain questions, Dr. Kabra. If anybody
Yeah.
wants to ask anything, please go
Yeah,
ahead.
there are questions. I'll take one by one from the chat, this question and answer, this thing.
Yes.
See, first is appendicitis more or less in CF kids, and also DIUS secondary thickening of the colonic mucosa in CF kids. Yes, appendicitis is more frequent. It may be, one is that appendicitis as such, and second thing is reversal of the appendicitis. And DIOS, distal intestinal obstruction syndrome, is because of the thickening and plugging. And this happens in the older age and later on. And as one of the clinical manifestation more commonly seen in India is something similar to that of a meconium ileus equivalent, in which there is a hypokalemia and which will cause a problem of ileus because of the pseudobarter syndrome. Then the second question is, can you share the Indian experience of Trikafta and its feasibility, affordability, acceptability, and safety and efficacy? I have touched upon it, but Trikafta is a combination of 3 drugs, very effective. We have experienced only one patient, and Orkambi we have 5 patients. So for this thing, Trikafta, the cost is around 23 lakh rupees a month, and it is very effective, can be indicated only if there is a one mutation is at least of a delta F508 mutation. And feasibility is that you have to import it from the German or from the other countries. German company is Vertex, and you can get it. There are some people who can facilitate getting it, but cost is a prohibitive factor. There is a recently, yesterday only, company in executive of the company in Argentina, they came to meet me, Gador, and they are willing to provide these medication much relatively much less cost of 5 6 lakh rupees per month, but they are not allowed to market Trikafta triple deck combination. So this is the feasibility, and if you have a patient possibly can afford, then you can just send me an email or something. I'll send the names of people who can get the medication. Okay, then any role of long-term antibiotic therapy like antifungals to prevent mortality from pneumonia in view of the immunocompromised nature of CF. CF is not immunocompromised, but because of thick viscid secretion, they are more prone for infection. And even if there is a fungal colonization, that will cause more of a allergic bronchopulmonary aspergillosis, less likely to produce an invasive fungal infection. So we generally use combination of steroids and antifungal for allergic bronchopulmonary aspergillosis, but prophylactic antifungal is not required. But prophylactic long-term antibiotic, as I had discussed, colonize with Pseudomonas, you will give colistin or tobramycin. Then there is another question. Azithromycin prophylaxis of SMA patients with a recurrent respiratory infection. Azithromycin is being used as an antibiotic as well as an immunomodulator. As far as CF is concerned, it is more of an immunomodulator. And if he's asking whether we can use it, SMA means spinal muscular atrophy. So we generally use it in non-CF bronchiectasis. So that is one of the indication very clearly defined. But for prophylaxis, you can use cotrimoxazole. That would be better one. Can we label a child with CF with a one CF mutation proved by NGS? So this is something like as there are so many mutations, and if you do a whole exome sequencing, in 95 to 98% of the time, you may be able to identify two alleles causing disease. But if there is a good clinical suspicion, phenotype is very good, and there are other supportive evidence in form of hypochloremic metabolic alkalosis and so on, you are justified in giving a label. But be careful that because if you see 1 in 22 may be carrier for the CF mutation, but all of them may not develop a disease. So that's why we should be very careful in this thing. Brand name of oral vitamin K, that is Kenadion, Kenadion, 10 milligram tablet. And as I said, below 10 kilo, half a tablet once a week, otherwise one tablet once a week. Okay, also please elaborate more on the cheaper diagnostic tool developed by AIMS and ways to acquire them. So the most cheapest diagnostic tool is history, culture of a sputum, aquagenic wrinkling, and electrolytes, and stool for fecal fat, and you may be able to make a diagnosis. As far as our system is concerned, you are most welcome. skkabra@hotmail.com. Send a mail. I'll explain it that how you can do this in our sweat system, sweat chloride system. Sweat chloride between 30 to 60, how to proceed. Also, if high clinical index of suspicion, but sweat chloride is less than 30, how to proceed further. So, to not to have unnecessary diagnosis, we should keep 60, or in infants, it may be 50, more than 50. But if it is borderline and clinical phenotype is significant, follow them as a suspected CF rather than giving them a label and give them a treatment. Then sweat chloride is less than 30. So we should try to avoid giving a label of cystic fibrosis to them. If clinical phenotype, treat them, and then better to discuss it with the geneticist whether the genotype is, some genotype may have a normal sweat chloride, but that is extremely rare. In general practice, we should not be following it.
Dr. Kabra?
Yes.
Dr. Anupam Sachdeva here. Good evening.
Yes, sir. Good evening. Good evening.
Sir, just wanted to know, has anybody estimated what is the lag period as far as cystic fibrosis is concerned?
Lag period, sir,
when I say lag period, it is like we calculate for our cancer patients when the first symptoms appear and the diagnosis is made. And has it reduced in the last 2 or 3 decades?
Yes, sir. One is that the children are symptomatic in utero, but our problem is age of diagnosis. So generally, when we first analyze our data, average age of diagnosis was 30 months, while they were symptomatic historically by age of 2 months. So there is a lag period that symptoms are there, but diagnosis was made at age of 3 years or so. Even from the data from Chandigarh, it suggests that it was 6 years. Now with widespread awareness, availability of these genetic mutations and sweat tests, the age of diagnosis is lower. In now the recent data analysis, it is in our cohort, it is around 18 months.
I think that's a good news, because that means that we will be catching them earlier
Yes,
and get a better long-term, outcome or prognosis.
Yes, sir, you are absolutely right. That if we can identify them early, then there will be a good prognosis. So now,
Dr. Devinder Sareen? Dr. Devinder?
Yes, sir.
Ma'am,
Sir, good evening,
yeah.
sir. Anupam
Good
Sachdev,
evening.
sir. Pranam, sir. Pranam.
Sir, any comments or questions?
Sir, I will say in one word, Gagar mein Sagar is the kahawat in Hindi. So Dr. Kabra has in 45 minutes everything about the very crispy for the cystic fibrosis.
Yeah.
Very important subject and covered extremely nicely, excellently covered, sir. Congratulations, Kabra, sir.
sir, namaste.
I think that was a masterclass in cystic fibrosis. Last comments by any of the chairpersons or the moderators?
Sir, yes, I am Dr. Renu Boralkar.
Yes,
it was
ma'am.
a very excellent talk by sir and eye-opener for all of us. And the history part which he said, the curve he showed, that is very important for us, for the low resource setting people to have a high suspicion. And also, thank you, sir, for calling us on this dais. Thank you so much.
I have one
Thank
question,
you.
Dr. Kabra.
Yes, sir.
Dr. Kabra, I have one question. Is the combination combination of modulator is a standard of care in Western countries?
Yes, sir. See, triple duct combination is now the standard of care, and it has improved significantly. Say, as I said, we have only one patient who could afford it because father is working in a public sector undertaking, and she has improved significantly. Her physiotherapy and other things have reduced significantly. So 3-drug combination, Trikafta, is the drug. But
Yes.
as of now, it is very expensive, 23 lakh rupees a month.
So if a patient have a single mutation, then also we can use a specific modulator.
Sir, there will be 2 mutations, and one mutation should be delta F508. Then we can use these combinations.
Well, on behalf of Institute of Child Health, Sir Gangaram Hospital, IAP Delhi, and I would like to thank both the chairpersons, Dr. Devinder Sareen, a very dear friend and professor and head of pediatrics at Gitanjali Medical College. Thank you very much, sir. Ma'am Boralkar, who's
Thank
at
you, sir.
Aurangabad. Thank you very much, ma'am. And of course, our star performer, Dr. Kabra, his excellence, his par excellence, and also Dr. Anil Sachdeva for bringing in a perspective from the private sector and explaining how they have started their chronic lung diseases forum. Thank you all. Dr. Alok Bhandari, would you like to say something?
नहीं सर, आपके बाद तो कोई बोलने की हम जरूरत कर ही नहीं सकते हैं.
सर वो आपका यूजुअल दे दो मैसेज की all those you should join Indian Academy of Pediatrics.
Sir, Anupam sir, thank you very much for blessing the occasion, sir. We feel proud.
Thank you very much, sir. Thank you very much.
Thank you.
Thank you. Yes.
Kabra sir,
Thank you.
thank you.
Thank you
Thank
very
you,
much.
Kabra sahab.
Thank you,
night,
Dr.
sir.
Kabra.
Anil Sachdev sir, Alok Bhandari sir, Renu madam.
Thank you.
Thank you very
Namaste,
much.
sir.
Thank you.
Thank you.
Bye bye.
Thank you, Dr. Mukesh. Thank you.
Thank you, one and all.
Thank you. Thank you.
Pleasure, sir.
Thank you. Thank you, sir. Thank you. Thank you, Anupam Sachdev sir. Thank you very much.
Thank you. Bye.
Bye. Bye.